Welcome to this presentation on the burden of bronchiectasis with a focus on non-cystic fibrosis bronchiectasis. I'm Patrick Flume. I'm a professor of medicine and pediatrics at the Medical University of South Carolina in Charleston.
Hi, I'm Mark Matursky. I'm a professor of medicine at the University of Connecticut.
The learning objectives for this program include recognize the burden of disease, patient risk factors, and comorbidities associated with non-CF bronchiectasis, to identify the role of neutrophilic inflammation and neutrophil serine proteases in bronchiectasis, describe the impact of pulmonary exacerbations in the natural history, clinical course, and disease progression of bronchiectasis, and to evaluate the potential impact of emerging therapies on disease management approaches for bronchiectasis. Now we'll discuss a focus on non-CF bronchiectasis pathophysiology, its clinical course, and emerging therapies.
We'll start with a discussion of the burden of disease, risk factors, and comorbidities, including epidemiology, diagnostic challenges, and how to differentiate bronchiectasis from similar and co-associated conditions. It's always important to start with a definition of what you're talking about. Bronchiectasis is essentially a radiographic definition based on the chest CT. Bronchiectasis is present when the airway diameter is larger than the diameter of the accompanying artery. Most clinicians use the inner diameter of the airway when making this assessment, although some believe that the outer diameter is more accurate because the inner diameter can be falsely decreased by airway wall inflammation. However, in my experience, using the outer diameter seems to result in more false positives. Other criteria include lack of normal airway tapering or a visible airway within 1 centimeter of the periphery or the pleural surface. However, you need to be careful when using this last definition, as you can see false positives due to atelectasis, which can bring the airway closer to the pleura than it normally would be. A recent publication attempted to define clinically significant bronchiectasis, but it's very important to realize that the rationale for this was for use in clinical trials, and it has not been validated for use in the clinic when dealing with patients on a clinical basis. Nevertheless, the definition included at least 2 of the following: cough most days of the week, sputum production most days of the week, and a history of exacerbations, of course, in the presence of the abnormal CT discussed above. There's been a marked increase in the prevalence of bronchiectasis in the US, as well as in other countries, over the past 20 years or so. The left panel shows you age-adjusted rates of bronchiectasis in 2001, approximately 110,000 estimated for the country as a whole. And the right panel shows you the estimated prevalence in 2013 of approximately 400,000. You can also see in the right panel that there is a female predominance at every age group, essentially. And again, increased prevalence in patients who are older. This other study corroborates that finding. They found in a different data set an 8.7% annual increase in bronchiectasis among Medicare patients from 2000 to 2007. And again, predominance in females, 36% more common. We also know that there are disparities in bronchiectasis prevalence, which presumably represents a disparity in diagnosis as opposed to actual less frequent occurrence of bronchiectasis in underrepresented minorities. This is likely due to limited access to specialized care, as well as other factors that can contribute to decreased recognition. On the positive side, in a study of patients seen at specialized centers that were participating in the bronchiectasis research registry in the United States, we did not see a disparity in quality of care. A 68-year-old female is referred to you for chronic cough. She has a history of mild intermittent asthma since childhood, but has not had recent exacerbations. She has daily yellow-green sputum. She has no other medical history, and her review of systems reveals no other symptoms. A high-resolution CT of the chest demonstrates bilateral lower lobe bronchiectasis. After appropriate testing, which of the following is most likely to be the cause of her bronchiectasis? So what are the etiologies of bronchiectasis? In discussion of this, it's important to understand that about 20% of cases will be found to have an underlying cause that is likely to result in a change in therapy. Some of these include allergic bronchopulmonary aspergillosis, non-tuberculous mycobacterial infection, immunodeficiency, the most common of which in adults is common variable immunodeficiency, alpha-1 antitrypsin deficiency, gastroesophageal reflux, and cystic fibrosis. Other commonly encountered causes include post-infectious, such as after severe pneumonia, pertussis, or measles, but I always take it with a grain of salt if a patient has a history of one of these, and I'm never really convinced that it's the cause unless the bronchiectasis clearly arose after the acute episode. Many patients will have had pneumonia or history of measles. It's not clear that their bronchiectasis is always due to those remote infections. We're seeing more and more bronchiectasis related to COPD and asthma. We're seeing less in the US related to prior tuberculosis, but we still see it. A substantial percentage are caused by autoimmune diseases, including Sjogren's syndrome and inflammatory bowel disease. We see primary ciliary dyskinesia and a host of other even rarer conditions that can lead to bronchiectasis. It's important also to understand that bronchiectasis is heterogeneous. Perhaps it's best referred to as a syndrome as opposed to one specific disease. We see large variations in the type of symptoms, the severity of symptoms, the underlying etiology, associated comorbidity, and frequency of exacerbations. We also see a lot of heterogeneity in the natural history or prognosis of bronchiectasis. Some patients remain completely asymptomatic or minimally symptomatic for many, many years or even their whole life. Others progress with increased severity of cough and quantity of daily sputum, increased frequency of exacerbations, progression towards increasingly pathogenic bacteria such as Pseudomonas, and some patients will have significant loss of pulmonary function and exertional limitations, but luckily most do not. And respiratory failure, while it can happen, again, is not extremely common. Unfortunately, we have no high-quality evidence that effective treatment impacts long-term prognosis, although it likely does. We just haven't done the right studies yet to prove that. With all of this heterogeneity, when should we suspect bronchiectasis? Certainly, the cardinal symptom is the chronic cough, often with chronic purulent sputum. And the chronic purulence distinguishes it from COPD in many cases, because in COPD, the sputum is usually not purulent except during exacerbations. Hemoptysis and chest pain are likely more common during exacerbations of bronchiectasis than during exacerbations of other chronic respiratory conditions such as COPD or asthma. Exacerbations may or may not be frequent. Another clue that we should pay attention to is the bacterial culture. Patients with bronchiectasis will often have organisms that are not as commonly encountered in patients with COPD and certainly asthma. Now, of course, H. flu is commonly seen in COPD, but more patients with bronchiectasis will have a positive culture. And organisms such as Pseudomonas, Staphylococcus aureus, Stenotrophomonas, and other gram-negatives are much more commonly seen in bronchiectasis as opposed to COPD. And of course, if a patient has one of the underlying causes that we've discussed previously, then bronchiectasis needs to be considered. Let's move on to discuss the recommended initial testing for patients with newly discovered bronchiectasis. Just about every patient should have pulmonary function testing with bronchodilator responsiveness to assess their baseline severity of disease and potential treatments to which they might be responsive to. The high-resolution CT scan of the chest has almost always been done to arrive at the diagnosis. Every patient should have a sputum sent for bacterial, mycobacterial, and at least initially a fungal culture, in part because allergic bronchopulmonary aspergillosis is a not unusual etiology. A CBC with differential should be sent to assess for eosinophilia, and quantitative immunoglobulin levels, IgG, IgA, and IgM, should be sent to look for immunodeficiency, again, most commonly common variable immunodeficiency. And I separate out the IgE level because we're not looking for immunodeficiency in testing the IgE level, but we are looking for evidence of an allergic component, hyper IgE syndrome, ABPA, things like that. And 40 to 50% of cases will remain idiopathic despite this testing. Getting back to the 68-year-old female in our case question, what is the correct answer as to the most likely cause of her bronchiectasis? The correct answer was unknown or idiopathic, which is approximately 40% of patients with bronchiectasis. While asthma, alpha-1 antitrypsin deficiency, and non-tuberculous mycobacterial infection all cause a significant percentage of cases of bronchiectasis, none of them are as common as patients who ultimately are diagnosed with idiopathic bronchiectasis.
Now we'll move on to the role of neutrophilic inflammation and neutrophil serine proteases in non-CF bronchiectasis. And here we'll talk about the pathophysiology, the clearance of neutrophils, and the role of inflammation, including the eosinophils. Classic model of the pathophysiology of bronchiectasis has been this cycle of events that one feeds upon another to cause this vicious cycle of progression of disease. It can start in just about any place, but in this example, let's start with an abnormal mucociliary clearance. So the airway mucus, any other material in the airway, is not being moved by the ciliary function and essentially remains static and retained in the airways. That becomes a ripe environment for bacterial infection. And these bacteria are introduced into the airway principally by aspiration, small amounts of aspiration. We introduce the bacteria. Most of us can clear those, but in the right setting, those bacteria can become opportunists and establish residence and multiply. There are some bacteria which are more commonly seen in patients with bronchiectasis. And when you look at any epidemiologic review, we typically see the same organisms. Pathogenic bacteria include Pseudomonas aeruginosa, Staph aureus, Haemophilus influenza, Stenotrophomonas. In many of these patients, you'll find more than one organism, which is why you see in this display that the sums are greater than 100%. We will also have patients in which we don't identify any pathogens, and we look to monitor for them to see if they do develop any acquisition of any pathogen that could be treated. Also realize that many of these patients will grow non-tuberculous mycobacteria, being increasingly found in our patients, and it is our practice to monitor for those over time. With infection comes inflammation. So a reasonable question to consider now is there a role for these inflammatory cells in response to the persistent infection in the airways? These inflammatory cells include neutrophils, lymphocytes, and eosinophils, and it becomes relevant to think about their role in contributing to the pathology of disease. In many of these patients, the inflammatory response is excessive and actually becomes injurious to the airways, and they actually do contribute to the pathology of disease. So I want to focus on the neutrophils first because they are the principal component, the inflammatory response, and the products that they release, these neutrophil elastases and other serine proteases, which are actually injurious to the airway. We've learned a lot about inflammation in bronchiectasis, and looking at this particular study as an example, looking at lavage fluid from patients with bronchiectasis, we first see that there is a marked increase in the number of cells that are present in the lower airways. Although the number of control subjects used in this study is small, they mirror what we know from a large body of evidence of what consists of normal inflammatory cells in the lower airways. So not only are the cell counts greater, the proportion of those cells which are neutrophils is markedly increased. Neutrophils are generally in low numbers in the healthy individual, but they're markedly increased in patients with bronchiectasis. And with the increase in neutrophils, you also see a marked increase in the neutrophil elastase, the serine proteases that are released into the airways. And that can be a wide range from, in some patients, a modest amount of increase in neutrophil elastase, and others, a marked increase in excessive amount of inflammation. This inflammatory response, it mirrors the bacterial load that we find in patients, and it correlates well with other clinical features of disease. And so if you look in the right panel, as we look at the increase in the bacterial load, which also correlates with the amount of neutrophil elastase, you see both an increase in the number of outpatient exacerbations in those patients, as well as a worse cough score, indicating greater symptoms associated with that increase in inflammatory response. The neutrophils have multiple roles that could participate in the pathology of disease. So the neutrophil elastase can increase mucin expression, so you get more material in the airway. It can impair ciliary activity, so you get greater retention of that. It causes injury to the epithelial cells and can actually hinder its repair. The inflammation that's present incites more inflammation, so it perpetuates itself, and it actually impairs that initial innate immune function. So there's a number of aspects of the elastase that can contribute to the development of disease. But the neutrophils are not the only cells of interest, and there has been a recent increase in the potential role of eosinophils in bronchiectasis. We know that there are pretty close association between blood eosinophilia and the eosinophils that we find in the sputum. And so when you look at the correlation in these figures, what you can see is that as you increase your numbers of blood eosinophils, you typically will see a higher number in the sputum as well. And so there is a greater presence of those eosinophils in the airways, and it's an intriguing association with disease. In this example, looking at that blood eosinophil count and its correlation with exacerbation, so looking at the time to the next exacerbation, you can see that as the blood eosinophil count has increased, suggesting that the sputum eosinophil count has also increased, the time to event is much shorter in those that have eosinophil counts greater than 300 per microliter. So there is great interest in the potential role of the eosinophil in disease as well. So that neutrophil inflammation is causing area injury and destruction. And with that injury, it causes further impairment in mucociliary clearance. And there you get the vicious cycle that just can sort of perpetuate itself. But we've learned more about this model and have introduced the concept of a vortex. And the purpose of this is not that just one step feeds the other. Each of these can feed on themselves. So for example, if you have impaired mucociliary clearance, not only does that create an environment that's ripe for infection, that impaired mucociliary clearance can't clear out the inflammation that has accumulated there, which is inciting more inflammation. That greater inflammation is not only causing injury to the epithelial cells, it also is impairing mucociliary clearance. And likewise, infection is not only creating injury to the airway, it's also inciting inflammation. So all of these processes seem to feed on each other, creating this vortex in the pathophysiology of disease.
Next, we're going to talk about the impact of pulmonary exacerbations on the natural history, clinical course, and disease progression of bronchiectasis. We'll cover recognizing and managing exacerbations and the impact of exacerbations on the patient. There was a recent consensus definition for exacerbation. Again, similar to the definition of clinically significant bronchiectasis, this definition was meant to be used for clinical research. The authors defined a significant exacerbation as one in which 3 or more of the following key symptoms lasted for at least 48 hours. Cough, sputum volume and or consistency, sputum purulence, breathlessness or exercise tolerance decrease, fatigue or malaise, or hemoptysis. Notably, they did not include chest pain, which is sometimes seen in bronchiectasis, but is less common, which is probably why they did not include it. And it's, again, important to note that if a patient calls you with only 24 hours of all 6 of these symptoms, for example, you're not going to say, sorry, no antibiotic. You've got to wait 48 hours. Again, this is for clinical research. Included in the definition is that a clinician determined that a change in treatment is required. And usually that is going to be an oral antibiotic. So what causes these exacerbations? It's safe to say that for a significant percentage, we don't know. At least 30% are due to respiratory viruses, which will often go undiagnosed, but there may be clues in that patients with respiratory viruses often will complain of upper respiratory symptoms such as sore throat or rhinorrhea. Interestingly, most exacerbations are not associated with a significant increase in sputum bacterial density, as seen in this study. So we can't just say that it's an increase in bacterial load causing these exacerbations. It may be that there's a new bacterial strain, although that has not been demonstrated conclusively. And again, for many of these, we just don't know. It's also important to note that there is a frequent exacerbator phenotype of patients with bronchiectasis, similar to COPD. So these are patients that have frequent exacerbations. And notably, this type of patient is likely to continue with that pattern. A 72-year-old female with bronchiectasis presents with 2 days of low-grade fever, left lower pleuritic chest pain, and increased cough with purulent sputum. A sputum culture grows Haemophilus influenza, a pathogen that she has previously grown. This is her 3rd exacerbation in 12 months. She improves back to her baseline with a course of doxycycline. Her maintenance bronchiectasis therapy includes twice-daily hypertonic saline nebulization, followed by high-frequency chest wall oscillation vest treatment, and thrice-weekly azithromycin. In discussing her exacerbations, what would you tell her about them? What other impacts are there on patients who have exacerbations? One thing it's important to mention is that there's so far no proven impact of exacerbations on disease progression, such as rate of FEV1 decline. However, if the pathophysiology mirrors COPD in any way, then there may be such an impact. We haven't done the right study yet. My suspicion is if we studied this rigorously, we would see a decline in FEV1 associated with frequency of exacerbation. In fact, the association does exist, but the causality has not been proven yet. Clearly, there's a negative impact on the patient quality of life associated with exacerbations, as we can see in this slide, where patients' SGRQ, St. George's Respiratory Questionnaire, severity of symptoms increases with exacerbation, and then during convalescence goes back down to the levels seen at baseline. What may be unrecognized by many people is that exacerbations are associated with a significant increased risk of acute vascular events, including acute cardiac events such as myocardial infarction and stroke. This study looked at the frequency of these types of events just before and just after exacerbations. The myocardial infarction risk was more than 4 times as high, and the stroke risk was about 60% higher shortly following an exacerbation. And this is probably because inflammation begets thrombosis. The frequent exacerbator patients certainly have worsened outcome, even though we haven't been able to specifically associate individual exacerbations with loss of function. In this study, we see that patients who had more frequent exacerbations had higher rates of hospitalization. And on the right, we can see that the frequency of exacerbations correlated with life expectancy. Getting back to our patient with frequent exacerbations, the correct answer is answer C. she's likely to continue having frequent exacerbations despite appropriate therapy, as she is a frequent exacerbator. And as of now, we don't have therapies that have been proven to markedly decrease the rate of exacerbations. Even patients who are on chronic macrolide therapies who will have fewer exacerbations on average still will continue to have exacerbations in general. The other answers are incorrect. Frequent exacerbations, luckily, rarely result in chronic respiratory failure. In fact, chronic respiratory failure is generally uncommon in patients with bronchiectasis, although certainly it can happen. Of course, even though she recovers after each exacerbation, they are of significant consequence to her. So B is incorrect. And unfortunately, D is incorrect, as starting her on inhaled antibiotics is not necessarily going to prevent future exacerbations. Unfortunately, most clinical trials of inhaled antibiotics have failed to show statistically and clinically significant decreases in exacerbations.
And now to talk about emerging therapies as well as current disease management approaches for non-CF bronchiectasis. We're going to talk about goals of therapy, how they approach the mechanism of action in terms of what they're trying to accomplish, as well as introduce you to some ongoing therapies in bronchiectasis. So our goals of treatment are few. Obviously, we want to relieve the symptoms that led to the diagnosis. They have cough, sputum production. We want to prevent progression of disease, and we'd like to prevent complications of disease. A key example of that are the exacerbations that can occur. So when we think about opportunities for treatment, I'm going to talk about those which are targeting the aspects of the pathophysiology of disease, but I don't want anyone to forget the other ancillary approaches to treatment. These are the other comorbidities and factors that are very, very important in taking care of these patients. Many of our patients will have symptoms of gastroesophageal reflux disease, and that can contribute to recurrent aspiration, and so that should be managed well. Patients who are malnourished do more poorly than those who are adequately nourished, so focusing on nutrition. Likewise, for other lung diseases, vaccination and pulmonary rehabilitation are useful therapies for our patients. So what are the therapies that are specific for bronchiectasis? So we have therapies that target the clearance of airway material as well as targeting infectious pathogens. But we don't have therapies that specifically target the inflammatory side of the treatment for these patients. So what are some of these current and potential treatment targets for bronchiectasis based on what we know about the pathogenesis? So here we can think about how we might augment mucociliary clearance to clear out the airway secretions. In those patients who are chronically infected, every drop of their sputum contains millions of bacteria. So if they can unload a quarter cup of sputum, they just unloaded an awful lot of infection. Likewise, they unloaded a lot of inflammation to try and reduce that incitement of more inflammation. So focusing on the airway clearance aspect of it, thinking about the microbiology as that might be a potential target, and it's why we encourage getting sputum cultures and monitoring them over time. So therapies that are typically used, and I want to give the caveat that there are none of these which are indicated, a labeled indication for this purpose, but they are published in guidelines to therapy. And so those opportunities for treatment, again, focusing on the impaired airway clearance and mucociliary clearance, that's where using airway clearance therapies, which can consist of breathing techniques or the use of devices to try to augment clearance of these secretions. We will frequently use nebulized hypertonic saline as a means of altering the properties of the phlegm and to increase cough clearance. Frequently in those patients who have frequent exacerbations, there is an opportunity to use chronic macrolide therapy. Now, there is some controversy about the mechanism of action of the macrolides, of whether they are truly functioning as an antibiotic or whether they have anti-inflammatory properties, and that's where they see the benefit. The challenge with looking at it as an antibiotic is it seems to have its greatest effect in those patients who are perpetually or persistently infected with Pseudomonas, and we don't typically think of the macrolides as having anti-Pseudomonal properties. In terms of the deal with inflammation, that is just a harder thing to measure, but there are data that demonstrate there is an anti-inflammatory effect of the macrolides. The caveat to the use of macrolides is we do not want to use them as monotherapy in patients who are infected with non-tuberculous mycobacteria. So it is good practice to look for mycobacteria before starting the macrolides and to monitor for their presence while patients are on chronic macrolide therapy. And then for infection, we obviously have antibiotics, and we can give these either systemically, intravenously, or orally, or we can give them topically by giving them through the aerosolized route. So the systemic antibiotic approach is typically used for the treatment of exacerbations, and they're not used typically for prophylactic, and only on occasions might be used for suppressive therapy. Aerosolized antibiotics are typically used again in those patients who have more frequent exacerbations and oftentimes with an organism which is going to be responsive. So typically that is Pseudomonas, and using something like the aminoglycosides to try and suppress the infection to try and reduce the frequency of exacerbations. So in terms of the mechanisms of action or recommended therapies or those that are in development, talked about a number of these medications. Hypertonic saline, although people think that initially it was enhancing mucociliary clearance by restoring airway surface liquid, we've since learned that it probably is doing more to hydrate the phlegm, to give it more flowable properties to be able to clear, but also to induce cough clearance to try to move these secretions further along. The macrolides, as I suggested, might have an anti-inflammatory property, but we can't discount that it is an antibiotic. The inhaled antibiotics are typically used in those patients who have frequent exacerbations, and most commonly in those patients who have persistent infection with Pseudomonas, to suppress the infection. Oftentimes is not successful with eradication. And then there are the DPP-1 inhibitors that I think are worthy of conversation. This is a novel product that's in development that has some intriguing approach to finally get us something that can address the inflammation in our patients. There are some other novel approaches to therapy which are under investigation, including trying to have even better mucociliary clearance. So as an example, there are folks who have used repurposed some medications and combined them to see if they can do an even better job of trying to improve airway clearance, such as combining ascorbic acid with reduced glutathione. There's another study in the UK looking at hypertonic saline with carbocysteine. And there also are other devices that are trying to use other principles of airway clearance to try and enhance these secretions. Important to know about the devices is that none have been demonstrated to be superior to another. The goal is to find which one works best for the patient. Usually the one that works best is the one they'll actually use. So it's important to introduce them to all the options. And then to deal with neutrophilic inflammation, the DPP-1 inhibitors, there's 2 programs ongoing looking at these products in trials to see if they can reduce exacerbations in our patients. As we had discussed earlier, that the neutrophils play a principal role in the pathogenesis of disease. There is an exaggerated inflammatory response. Those neutrophils persist in the airways. They're not cleared out by the mucociliary clearance. And with those neutrophils comes neutrophil elastase. Those levels correlate with the presence of Pseudomonas aeruginosa. Those levels correlate with more frequent exacerbations. And so you can think strategically of how you might try to reduce that. You could develop therapies that might reduce the number of neutrophils in the airways. And there have been trials looking at trying to block that, but that might actually increase their risk of developing other types of infection. And then there are a strategy of trying to reduce the quantity of neutrophil elastase in the airways, either by sopping it up, which has been tried with things like alpha-1 antitrypsin, but it just has not been successful because the quantity is just too large. Since then has been the discovery of the dipeptidyl peptidase 1 which is an important enzyme which essentially activates the serine proteases as they're being loaded up into the neutrophils in the bone marrow. And if you can inhibit DPP1, then you can essentially reduce the quantity of neutrophil elastase, of activated neutrophil elastase present in these neutrophils, essentially like taking bullets out of their gun. So you don't reduce the number of neutrophils, you're just trying to reduce the quantity of neutrophil elastase. So in the clinics, this has been demonstrated to be effective in the sense of putting patients on a DPP1 inhibitor. You can see in the figure on the right that there was in fact a reduction of the sputum neutrophil elastase concentration while these subjects were on one of two doses of the DPP1 inhibitor. And then after they came off of the product, the neutrophil elastase level then again increased in the sputum. So in that 24-week trial, it was able to demonstrate that there was a marked reduction of the effect, so that was achieving the mechanism of action intended for this product. But that alone isn't going to get you an approval. You need to demonstrate a clinical benefit. And so in a phase 2 study of a DPP1 inhibitor, looking at the time to first exacerbation, what you can see here is there was considerable improvement at both of the doses that were tested compared to the placebo. So that was an intriguing result, and now prompting that program into phase 3 clinical trial testing.
Key takeaways from this session include the following. Bronchiectasis is increasingly being identified, demonstrating an increase in the prevalence of this condition. Mucociliary clearance is adversely affected in bronchiectasis, creating an environment where opportunistic bacteria can persist and incite an exaggerated inflammatory response, perpetuating the problem. Exacerbations of bronchiectasis result in worsened quality of life and are associated with worsened patient outcomes. Current recommended therapies address some aspects of the pathophysiology of the disease, i.e. airway clearance and bacterial infection. However, there are ongoing studies to address inflammation in bronchiectasis, one of the remaining causes not currently being addressed adequately.
Now we'd like to engage you in an interactive case-based discussion, applying real-world strategies to address the burden of bronchiectasis. Let me present our case of a 55-year-old female with a known history of bronchiectasis. She has other additional history in that she is a non-smoker, but does describe symptoms of esophageal reflux. She has a daily cough that's productive of yellowish sputum, and she has been treated with antibiotics for pulmonary exacerbations at least twice per year in the last few years. Her body mass index is only 16.3, and she has obstructive airways disease with an FEV1 of 42% of predicted. Sputum cultures have grown Pseudomonas aeruginosa, but mycobacterial cultures have been negative. So how might imaging assist with the differential diagnosis? Mark, what imaging studies would you perform?
Well, certainly she must have had a CT scan to identify her bronchiectasis. One question that comes up is how often should she have CT scans? And there's a wide variety of practice regarding this issue. My personal belief is that most patients don't need frequent serial CT scans. In general, I reserve repeat CT scans for patients who have a change in their clinical condition that makes me think I need to search for something else going on, a complication, development of non-tuberculous mycobacterial infection, or something like that. There are other selected situations where I will do CT scans more regularly, such as a patient with NTM infection that's very mild, who I'm not actively treating, but I'm going to want to know if it's progressing, even if the patient's symptoms aren't telling me that. But by and large, most patients, I believe, don't need frequent CT scans.
So I would like to see the CT scan because there may be clues in there that might help understand the differential. We had previously recommended what testing to be done, but these patients, particularly if she has symptoms of esophageal reflux, could there be features that would be compatible with recurrent aspiration, such as lower lobe disease or even more focal disease? That's the area where things keep going. Could there be any esophageal dilation that might suggest impaired esophageal motility? Another feature is if they have a lot of central bronchiectasis, even though she was likely evaluated for allergic bronchopulmonary aspergillosis, there are patients who will not have positive testing when you look, but will develop positive testing as time goes on. And so it's worth considering rescreening some of these patients periodically. So imaging was performed, and a few slices are provided here. And there are some important findings on here. Number one is she has diffuse disease. Diffuse meaning it's bilateral, it's in the upper lobes, it's in the lower portions of her lung, which generally means that there's some other systemic issue that could be causing her disease. The second finding is that she's got mucus plugging. You'll see some airways in here that are essentially plugged with mucus, as well as an increase in the airway wall thickness. And both of these are signs of increased phlegm in the airways, suggesting that there's certainly increased inflammation and highly likely that there is persistent infection in the space. So what would be the treatment goals for this patient?
This patient has a lot of symptoms on a daily basis. Her quality of life can't be very good. And in addition, she's having frequent exacerbations. So we would want to tackle both of those to the extent possible. For the daily cough and sputum, I didn't hear that she was on airway clearance. And certainly, even if she was, you would want to have a discussion as to how often she's using it. Is what's been prescribed right for her, given her lifestyle? People who are busy may not be able to drag out a high-frequency chest wall oscillation vest twice daily. So you sometimes have negotiations about what they can do. I have a patient who his optimum treatment was one of the handheld devices that he did in the car because his work frequently involved driving. So certainly airway clearance is a goal. Preventing exacerbations. This is a patient who, if she's not on a chronic macrolide, you would think about starting that, then assessing the response, and then even consider an inhaled antibiotic if the response was not excellent. In addition, there are some clues to comorbidities that can be addressed, potentially improving her quality of life. She has reflux, which could be contributing to the pathophysiology of the condition. As I say to my patients, it's probably not a good idea if we're dumping acid into your lungs every night, and that acid also has bacteria in it. So you would want to address her reflux. At the very least, an acid-reducing medication. But I've had patients who didn't respond wonderfully to medication, but then when you put them on a reflux diet, elevate the head of their bed, tell them to avoid food and drink prior to bedtime, they improve greatly. She's malnourished, so you would want to take steps to help her improve her nutrition, which is by definition going to improve her immune function. And I noticed that her FEV1 is around 40%, so she would be a candidate for pulmonary rehab. And if she's having significant exercise limitation, that would be a good thing to consider for this patient.
And as Dr. Matursky had alluded to, the principal symptoms were the daily cough, but also the exacerbations. So sort of rise to the top in terms of what are you trying to make better for this particular patient? And then summarized here are those opportunities for treatment that Dr. Matursky also has alluded to. Certainly to deal with the cough, focusing on airway clearance therapies, potentially using hypertonic saline. For the frequent exacerbations, the potential is using chronic macrolides. We've told that the cultures have been negative for mycobacteria. If that's a decision that has been started, monitoring to make sure that she doesn't acquire mycobacteria. The persistent Pseudomonas infection becomes an opportunity for aerosolized antibiotics. And then, as Dr. Matursky also talked about, he focused on the nutrition, trying to get her weight up, focused on the esophageal reflux, pulmonary rehabilitation, and vaccination. A critical piece to this, though, is you don't want to do everything all at once. You want to focus on the ABCs, and so focus on the most basic therapies, such as the airway clearance and the other nutritional and reflux therapies, and then perhaps make a decision about whether to go with a macrolide or an aerosolized antibiotic based on what's most suitable for her and her lifestyle. So some key clinical takeaways from this case. She offered an example of multiple opportunities for intervention, but we must prioritize where to start and what to monitor during that treatment course. And so with that, we will close the program and thank you for your participation.